44 peptic ulcer disease and related acid-associated disorders. Paul F. Sony, Anthony E. Zimmerman. I. Introduction. Definition. 1. Peptic ulcer disease (PUD) refers to a group of disorders characterized by circumscribed lesions of the mucosa of the upper gastrointestinal GI tract, particularly the stomach and duodenum. The lesions occur in regions exposed to gastric juices. 2. Gastroesophageal reflux disease (GERD) refers to the retrograde movement of gastric contents from the stomach into the esophagus. Reflux may occur without consequences, and thus be considered a normal physiological process, or it may lead to profound symptomatic or histological conditions, for example, GERD. When reflux leads to inflammation with or without erosions or ulcerations of the esophagus, it is called reflux erosive esophagitis. Most patients, 50% to 70%, report typical symptoms but lack evidence of esophageal mucosal injury, non-erosive reflux disease, NERD. 3. Dyspepsia is defined as persistent or recurrent abdominal pain or abdominal discomfort centered in the upper abdomen. B. Manifestations. 1. Duodenal ulcers almost always develop in the duodenal bulb, the first few centimeters of the duodenum. A few, however, arise between the bulb and the ampulla. 2. Gastric ulcers form most commonly in the antrum or at the antral fundal junction. 3. Less common forms of peptic ulcer disease. A. Stress ulcers result from serious trauma or illness, major burns, coagulopathy not related to anticoagulant therapy, need for mechanical ventilation 48 HRS, or ongoing sepsis. The most common site of stress ulcer formation is the proximal portion of the stomach. B. Zollinger-Ellison syndrome is a severe form of peptic ulcer disease in which intractable ulcers are accompanied by extreme gastric hyperacidity and at least one gastrinoma, a non-islet cell tumor of the pancreas or another site. C. Stomal ulcers, also called marginal ulcers, may arise at the anastomosis or immediately distal to it in the small intestine in patients who have undergone ulcer surgery and have experienced subsequent ulcer recurrence after a symptom-free period. D. Drug-associated ulcers occur in patients who chronically ingest substances that damage the gastric mucosa, such as nonsteroidal anti-inflammatory drugs, NSAIDs. 4. Reflux esophagitis is most often recognized by the presence of recurrent symptoms, for example, heartburn or altered epithelial morphology visualized radiologically, endoscopically, or histologically. Heartburn is substernal burning or regurgitation that may radiate to the neck. Other symptoms include belching, water breath, chest pain, asthma, chronic cough, hoarseness, and laryngitis. B. Endoscopic evaluation detected Barrett esophagus. B in 6% of patients with frequent heartburn. Barrett's esophagus is a premalignant condition that may lead to adenocarcinoma of the esophagus or esophagogastric junction. Peptic ulcer disease and related acid-associated disorders 887. C. Epidemiology. 1. Incidence. Peptic ulcer disease is the most common disorder of the upper GI tract. The duodenal ulcers affect 4% to 10% of the United States population. Gastric ulcers occur in 0.03% to 0.05% of the population. B. Nearly 80% of peptic ulcers are duodenal. The others are gastric ulcers. C. Most duodenal ulcers appear in people between age 20 and 50. Onset of gastric ulcers usually occurs between age 45 and 55. D. The 1 to year point prevalence of active gastric or duodenal ulcer in the United States in men and women is about 1.8%. The lifetime prevalence of peptic ulcer ranges from 11% to 14% for men and 8% to 11% for women. E. Approximately 10% to 20% of gastric ulcer patients also have a concurrent duodenal ulcer. F. In the United States, 44% of the adult population experience heartburn at least once a month. 14% take some type of indigestion medication at least twice a week. Of patients with GERD symptoms who have undergone endoscopy, 50% to 65% have apparent esophagitis. G. The annual prevalence of dyspepsia in Western countries is approximately 25%. 2% to 5% of primary care consultations are for dyspepsia. 2. Hospitalization. A. Hospitalization rates in the United States for peptic ulcers have been declining. These rates dropped from 25.2 per 10,000 in 1965 to 16.5 per 10,000 in 1981. This reflects a decrease in hospitalization for uncomplicated cases owing to increased outpatient diagnosis and treatment. There has been little change in hospitalization rates since then. B. There has been little or no decrease in duodenal ulcer perforations, and only a slight decrease in hemorrhages. 3. Mortality. A. The mortality rate for gastric ulcers declined between 1962 and 1979 from 3.5 per 100,000 to 1.1 per 100,000. B. For duodenal ulcer, the mortality rate declined from 3.1 per 100,000 to 0.9 per 100,000. C. Although death from GERD is uncommon, morbidity is not, because of the prevalence of the well-recognized complications such as esophageal ulceration, 5%, stricture formation, 4% to 20%, and the development of Barrett columnar-lined esophagus, 8% to 20%. D. Description. 1. Ulcer size. The average duodenal ulcer typically has a diameter 1 centimeter. Most gastric ulcers are somewhat larger, 1 to 2.5 centimeters in diameter. 2. Most ulcers are sharply demarcated and have a round, oval, or elliptical shape. 3. The mucosa surrounding the ulcer typically is inflamed and edematous. 4. Ulcers penetrate the muscularis propria and, in some cases, extend into the serosa or even into the pancreas. 5. Fibrous tissue, granulation tissue, and necrotic debris form the ulcer base. During ulcer healing, a scar forms as epithelium from the edges covers the ulcer surface. 6. Nearly all duodenal ulcers are benign. Up to 10% of gastric ulcers are malignant. E. Cause. The two major observations regarding PUD are the causal relationship among NSAID intake, gastroduodenal mucosal injury, the pathogenesis of gastric ulcer, and, to a lesser extent, duodenal ulcer, and the association of Helicobacter pylori infection in the pathogenesis of duodenal ulcer, and to a lesser extent, gastric ulcer. 1. H. pylori, formerly Campylobacter pylori, is a gram-negative microaerophilic, spiral bacterium with multiple flagella that lives and infects the gastric mucosa. This bacterium is able to survive in the acidic gastric environment by its ability to produce urease, which hydrolyzes urea into ammonia. Ammonia neutralizes gastric hydrochloric acid, HCl, creating a neutral cloud surrounding the organism. In the United States, the prevalence of H. pylori increases with age from approximately 10% at 20 years of age to approximately 50% at 60 years of age. Approximately 17% of H. pylori-positive individuals will develop a duodenal ulcer. Prevalence is higher in developing countries. B. H. pylori is associated with several common GI disorders. 1. Always present in the setting of active chronic gastritis. 2. Present in the vast majority of duodenal, 90%, and gastric, 60% to 90% ulcers. Recent studies indicate a decline in the prevalence of H. pylori in duodenal ulcer patients. 3. Sometimes present with non-ulcer dyspepsia, probably in 50% of cases. Eradication of pylori, when present, leads to symptom improvement in only about one-half of treated patients. 4. In gastric cancer, 85% to 95%. Although the association is strong, no causal relationship has yet been proven in gastric cancer. The World Health Organization has classified H. pylori as a Group 1 carcinogen. C. H. pylori eradication can cure peptic ulcers and reduce ulcer recurrence. It can eliminate the need for maintenance therapy in many ulcer patients. 2. Genetic factors. The lifetime prevalence of developing an ulcer in first-degree relatives of ulcer patients is about threefold greater than in the general population. This may be secondary to clustering of H. pylori within families. B. People with blood type O have an above-normal incidence of duodenal ulcers. 3. Smoking. Smokers have an increased risk of developing peptic ulcer disease. In addition, cigarette smoking delays ulcer healing and increases the risk and rapidity of relapse after the ulcer heals. Nicotine decreases biliary and pancreatic bicarbonate secretion. Smoking also accelerates the emptying of stomach acid into the duodenum. 4. NSAIDs. When ingested chronically, aspirin, indomethacin, and other NSAIDs promote gastric ulcer formation. These drugs may injure the gastric mucosa by allowing back diffusion of hydrogen ions into the mucosa. B. NSAIDs also inhibit the synthesis of prostaglandins, which are substances with a cytoprotective effect on the mucosa. C. Selective cyclooxygenase 2, COX-2 inhibitors, celecoxib or rofecoxib, are associated with fewer ulcers than non-selective NSAIDs, with rates comparable to placebo at 3 months. Questions regarding long-term safety of COX-2 inhibitors remain. With the recent documentation of increasing COX-2 expression with the progression of B to cancer, trials have been initiated using COX-2 selective inhibitors in B patients to prevent development of cancer. 5. Alcohol. A known mucosal irritant, alcohol causes marked irritation of the gastric mucosa if ingested in large quantities at concentrations of 20% or greater. The only association between ethanol intake and ulcer disease exists in patients with portal cirrhosis. 6. Coffee. Both regular and decaffeinated coffee contain peptides that stimulate release of gastrin, a hormone that triggers the flow of gastric juice. However, a direct link between coffee and peptic ulcer disease has not been proven. 7. Corticosteroids. Controversy over whether systemic corticosteroid therapy is associated with increased risk for the development of peptic ulcer disease has, for the most part, been resolved. Evidence for this direct association has always been weak in previous retrospective reviews trials and reflected the concurrent use of an NSAID. Current data support no link between steroids and peptic ulcer disease in the absence of concurrent NSAID use. 8. Associated disorders. Peptic ulcer disease is more common in patients with hyperparathyroidism, emphysema, rheumatoid arthritis, and alcoholic cirrhosis. 9. Advanced age. Degeneration of the pylorus permits bile reflux into the stomach, creating an environment that favors ulcer formation. 10. Psychological factors. Once assigned key roles in the pathogenesis of PUD, stress and personality type now are viewed as relatively minor influences. F. Pathophysiology. Ulcers develop when an imbalance exists between factors that protect gastric mucosa and factors that promote mucosal corrosion. Approximately 90% of patients with duodenal ulcer and 70% of patients with gastric ulcer have H. pylori infection. 1. Protective factors. Normally, the mucosa secretes a thick mucus that serves as a barrier between luminal acid and epithelial cells. This barrier slows the inward movement of hydrogen ions and allows their neutralization by bicarbonate ions in fluids secreted by the stomach and duodenum. B. Alkaline and neutral pancreatic biliary juices also help buffer acid entering the duodenum from the stomach. C. An intact mucosal barrier prevents back diffusion of gastric acids into mucosal cells. It also has the capacity to stimulate local blood flow, which brings nutrients and other substance. S2. 888, Chapter 44 ASAR. E. Peptic ulcer disease and related acid-associated disorders 889. The area and removes toxic substances, for example, hydrogen ions. Mucosal integrity also promotes cell growth and repair after local trauma. 2. Corrosive factors. Peptic ulcer disease reflects the inability of the gastric mucosa to resist corrosion by irritants, such as pepsin, HCl, and other gastric secretions. A. Exposure to gastric acid and pepsin is necessary for ulcer development. B. Disrupted mucosal barrier integrity allows gastric acids to diffuse from the lumen back into mucosal cells, where they cause injury. 3. Physiological defects associated with peptic ulcer disease. Researchers have identified various physiological defects in patients with duodenal and gastric ulcers. Duodenal ulcer patients may have the following defects. 1. Increased capacity for gastric acid secretion. Some duodenal ulcer patients have up to twice the normal number of parietal cells, which produce HCl. B. Nearly 70% of duodenal ulcer patients have elevated serum levels of pepsinogen I and a corresponding increase in pepsin secreting capacity. 2. Increased parietal cell responsiveness to gastrin. 3. Above normal postprandial gastrin secretion. 4. Defective inhibition of gastrin release at low pH, possibly leading to failure to suppress postprandial acid secretion. 5. Above normal rate of gastric emptying, resulting in delivery of a greater acid load to the duodenum. B. Gastric ulcer patients typically exhibit the following characteristics. Deficient gastric mucosal resistance, direct mucosal injury, or both. B. Elevated serum gastrin levels in acid hyposecretors. C. Decreased pyloric pressure at rest and in response to acid or fat in the duodenum. D. Delayed gastric emptying, increased reflux of bile and other duodenal contents. F. Subnormal mucosal levels of prostaglandins. These levels normalize once the ulcer heals. 4. GERD requires both initiation and perpetuation of the reflux of gastric contents. Esophagitis develops when noxious substances in the refluxate, that is, acid, pepsin, are in contact with the esophageal mucosa long enough to cause irritation and inflammation. In patients with GERD, 65% of reflux events occur via transient lower esophageal sphincter relaxation, ulcer. The main difference between normal individuals and those with GERD is the frequency of ulcer. GERD patients have more frequent and prolonged ulcer. Ulcer represents a decrease in lower esophageal sphincter, less pressure that is not associated with swallowing or peristalsis. B. Other mechanisms of less incompetence are increased abdominal pressure and spontaneous reflux during periods of very low less pressure. C. Such motility problems are permissive, that is, they allow reflux of acid and other noxious substances. 5. Many diseases cause dyspeptic symptoms, including PUD, GERD, gastric cancer, and biliary tract disease. However, in many cases, no clear pathological reason for a patient's symptoms can be determined. Dyspepsia in the absence of an identifiable organic cause is frequently described as functional or non-ulcer dyspepsia. G. Clinical presentation. Signs and symptoms of PUD vary with the patient's age and the location of the lesion. Only about 50% of patients experience classic ulcer symptoms. The remainder are asymptomatic or report vague or atypical symptoms. 1. Pain. Patients typically describe heartburn or a gnawing, burning, aching, or cramp-like pain. Some patients report abdominal soreness or hunger sensations. It is unclear whether peptic ulcer pain results from chemical stimulation or from spasm. Duodenal ulcer pain usually is restricted to a small, mid-epigastric area near the xiphoid. Pain may radiate below the costal margins into the back or the right shoulder. Pain from a duodenal ulcer frequently awakens the patient between midnight and 2 a.m. It is almost never present before breakfast. 890. Chapter 44I. G. B. Gastric ulcer pain is less localized. It may be referred to the left subcostal region. Gastric ulcer rarely produces nocturnal pain. C. GERD patients most commonly present with heartburn, belching, regurgitation, or water brash. Atypical presentations include chest pain, hoarseness, laryngitis, loss of dental enamel, asthma, chronic cough, or dyspepsia. Complications of GERD include esophageal ulceration, strictures, B. An adenocarcinoma of the esophagus or esophagogastric junction. D. Dyspepsia applies broadly to a range of symptoms, including abdominal or retrosternal pain and discomfort, heartburn, nausea, vomiting, and other symptoms referable to the proximal GI tract. E. Food usually relieves duodenal ulcer pain but may cause gastric ulcer pain. This finding may explain why duodenal ulcer patients tend to gain weight, whereas gastric ulcer patients may lose weight. Pain characteristically occurs 90 mins to 3 HRS after meals in duodenal ulcer patients, whereas pain in gastric ulcer patients is usually present 45 to 60 mins after a meal. Food aggravates reflux disease. 2. Nausea and vomiting may occur with either ulcer type. 3. Disease course. Both duodenal and gastric ulcers tend to be chronic, with spontaneous remissions and exacerbations. Within a year of the initial symptoms, most patients experience a relapse. In many cases, relapse is seasonal, occurring more often in the spring and autumn. B. All patients with a confirmed duodenal or gastric ulcer should be tested for H. pylori infection. If the patient is H. pylori positive, Eradication therapy will reduce the recurrence rate significantly and preclude the need for maintenance medication. C. GERD is also a chronic disease. Most patients with reflux esophagitis who are healed with antisecretory drug therapy will experience a recurrence within 6 months of discontinuation of the healing regimen. Maintenance therapy reduces the recurrence of esophagitis. H. Clinical evaluation 1. Physical findings. Patients with peptic ulcer disease may exhibit superficial and deep epigastric tenderness and voluntary muscle guarding. With duodenal ulcer, patients also may show unilateral spasm over the duodenal bulb. Gastric ulcer patients may have weight loss. 2. Diagnostic test results. A. Blood tests may show hypochromic anemia. B. Stool tests may detect occult blood if the ulcer is chronic. C. Gastric secretion tests may reveal hypersecretion of HCl in duodenal ulcer patients and normal or subnormal HCl secretion in gastric ulcer patients. D. Upper GI series barium X-ray reveals the ulcer crater in up to 80% of cases. Duodenal bulb deformity suggests a duodenal ulcer. E. Upper GI endoscopy. The most specific test may be done if barium X-ray yields inconclusive results. This procedure confirms an ulcer in at least 95% of cases and may detect ulcers not demonstrable by radiography. F. Biopsy might be necessary to determine whether a gastric ulcer is malignant. G. H. Pylori status is determined by non-invasive tests not requiring endoscopy or invasive methods requiring endoscopy. 1. Non-invasive. Serology, the test of choice when endoscopy is not indicated, is inexpensive. Several office tests are available. Breath tests can also be used to detect the organism and are uniquely suited as non-invasive means of confirming eradication of H. pylori after therapy. False negative breath tests may occur in patients receiving proton pump inhibitors, antibiotics, or bismuth compounds. 2. Invasive. These methods include histological visualization of H. pylori or measurement of urease activity, which require biopsy. First treatment objectives. 1. Relieve pain and other symptoms and promote healing. 2. Prevent complications. 3. Minimize recurrence. Eradicate H. pylori and PUD. 4. Maintain adequate nutrition. 5. Teach the patient about the disease to improve therapeutic compliance. 6. Maintain the patient symptom-free. Peptic ulcer disease and related acid-associated disorders. 891. Second therapy. Drug therapy. Peptic ulcer patients usually are treated with antacids, histamine 2H2 receptor antagonists, or proton pump inhibitors. Other drugs are added as necessary. Drug regimens that suppress nocturnal acid secretion are found to result in the highest duodenal ulcer healing rates. Drug therapy typically provides prompt symptomatic relief and promotes ulcer healing within 4 to 6 weeks. Figure 44-1. GERD management requires more aggressive acid suppression regimens. The pharmacodynamic endpoint is to maintain the pH in the esophagus at 4 or more. Figure 44-2. 1. Antacids. These compounds, which neutralize gastric acid, are used to treat ulcer pain and heal the ulcer. Studies show antacids and H2 receptor antagonists to be equally effective. Antacids are available as magnesium, aluminum, or calcium. The most widely used antacids are mixtures of aluminum hydroxide and magnesium hydroxide, Table 44-1. Duodenal ulcers rarely occur in the absence of acid or when the hourly maximum acid output is 10 mQ. Peptic activity decreases. First presentation of endoscopy or upper GI series. Advice about smoking and NSAIDs. Seen at endoscopy. Positive, negative. Biopsy urease test for H. pylori, take 2 biopsies if Keela negative histology. Seen on upper GI series. Poor specificity and sensitivity. Sent for histology, consider false negative test. Consider other causes of duodenal ulceration. Positive. Negative. Office-based serology test. For H. pylori, advisable with GI series. Review diagnosis and X-ray, consider other diagnoses. Eradicate H. pylori. Figure 44-1. Treatment strategy for management of duodenal ulcer. Campylobacter-like organism. Duodenal ulcer. GI. Gastrointestinal. NSAIDs. Non-steroidal anti-inflammatory drugs. 892 Chapter 44-2. As acidity decreases, experimental ulcer formation is inhibited by antacids, and acid-reducing operations cure ulcers. Mechanism of action and therapeutic effects. Antacids reduce the concentration and total load of acid in the gastric contents. By increasing gastric pH, antacids also inhibit pepsin activity. In addition, they strengthen the gastric mucosal barrier. B. Choice of agent. 1. Non-systemic antacids, for example, magnesium or aluminum substances, are preferred to systemic antacids, for example, sodium bicarbonate, for intensive ulcer therapy because they avoid the risk of alkalosis. Symptoms. Classic episodic symptoms not exceeding 4 weeks duration. Recommend OTC. Therapy with antacid, H-Tora, or H-Tora-contacid combination. Symptoms controlled. PPI therapy trial standard. Dose. Symptoms persist for GT. 4 weeks. Severe, frequent, or prolonged, regularly exceeding 4 weeks duration. Physician evaluation. Alarm or severe symptoms present. Alarm or severe symptoms absent. Symptoms persist. Symptoms controlled. PPI therapy trial high dose. B. Symptoms persist. Referral to gastroenterologist for further evaluation and/or EGD maintain therapy. Figure 44-2. Treatment strategy for management of gastroesophageal reflux disease. EGD. Esophagogastroduodenoscopy. H-Tora. Histamine 2 receptor antagonist. OTC. Over-the-counter. PPI. Proton pump inhibitor. Adapted with permission from Peterson W.L. GERD Evidence-Based Therapeutic Strategies, AGA Consensus Development Panel, 2002. Available at www.gastro.org/user-assets/documents/GERD-monograph.pdf. Peptic ulcer disease and related acid-associated disorders 893. 2. Liquid antacid forms have a greater buffering capacity than tablets. However, tablets are more convenient to carry. With either dosage form, the size and frequency of doses may limit patient compliance. 3. Antacid mixtures, for example, aluminum hydroxide with magnesium hydroxide, provide more even, sustained action than single-agent antacids and permit a lower dosage of each compound. In addition, compounds in a mixture may interact so as to negate each other's untoward effects. For instance, The constipating effect of aluminum hydroxide may counter the diarrhea that magnesium hydroxide frequently produces. 4. Calcium carbonate usually is avoided because it causes acid rebound, may delay pain relief and ulcer healing, and induces constipation. Another potential adverse effect of this compound is hypercalcemia. The risk is increased if calcium carbonate is taken with milk or another alkaline substance. The milk alkali syndrome, that is, hypercalcemia, alkalosis, azotemia, nephrocalcinosis, can also occur. C. Administration and dosage. 1. Antacids differ greatly in acid neutralizing capacity and C. Defined as the number of milliequivalents, μQ of a 1N solution of HCl, that can be brought to a pH of 3.5 in 15 mins. For most duodenal ulcer patients, approximately 50 mCi of available antacid is needed for ongoing neutralization of gastric contents. Therefore, the required dosage depends on the ANC of the specific antacid. 2. In the fasting state, antacids have only a transient intragastric buffering effect, 15 to 20 mins. When ingested 1 HR after a meal, they have a much more prolonged effect, about 3 to 4 HRs. Therefore, they should optimally be taken 1 and 3 HRs after meals and before sleep. Consequently, the typical antacid regimen calls for doses 1 and 3 HRs after meals and at bedtime. Table 44-1 Comparison of common antacids. Therapeutic amount. Acid neutralizing capacity 140 mg/ml or sodium content. Brand name mCl or tab, no. Of tablets. AMG 5 ml or tablet. Regular liquids. Aluminum hydroxide, magnesium hydroxide, simethicone gelicyl 2. 458 0.09 Maalox max 5.2 27 0 Milana 2.556 0.03 Milana max strength 5.2 hydroxide alternagle 435 0.20 Tablets. Calcium carbonate. Maalox advanced max strength 560 tums 1014 0 tums EX 159.3 0.11 Titrolac 7.5 18.7 Carbonate and magnesium hydroxide rolades 8.5 16.5 0.04 Mylanta Ultra 12.8 8.40 Aluminum hydroxide and magnesium carbonate Gaviscon extra strength 8 1629 894 chapter 44 2 3 dosage are because the ANC of antacid products vary widely. No standard dosage can be given in terms of milliliters of suspension or number of tablets. However, patients with duodenal ulcers generally require individual dosages of 80 to 160 mCi of ANC, equivalent to 30 to 60 milliliters of Mylanta or Maalox. Thus, the total daily dosage may be as much as 420 milliliters of Mylanta or Maalox if the standard 7 times daily dosing regimen is used. Because of the large doses required, increase in adverse effects, need for frequent administration, and poor patient compliance, Their role in the management of PUD is limited. B. Antacid therapy usually continues for 6 to 8 weeks. D. Precautions and monitoring effects. 1. Calcium carbonate and magnesium-containing antacids should be used cautiously in patients with severe renal disease. 2. Sodium bicarbonate is contraindicated in patients with hypertension, congestive heart failure, severe renal disease, and edema. It should not be used for ulcer therapy. 3. All antacids should be used cautiously in elderly patients, particularly those with decreased GI motility, and renally impaired patients. 4. Aluminum-containing antacids should be used cautiously in patients who suffer from dehydration or intestinal obstruction. The combination of calcium carbonate with an alkaline substance, for example, sodium bicarbonate, and milk may cause the milk alkali syndrome. 6. Always check brand name extension products for major ingredient changes, that is, Maalox Total Stomach Relief contains bismuth subsalicylate. 7. Chronic administration of calcium carbonate containing antacids should be avoided because of hypercalcemia and calcium ion stimulation of acid secretion. 8. Aluminum or magnesium toxicity is unlikely in patients with normal renal function. The encephalopathy of tissue deposition of aluminum occurs only in dialysis patients receiving aluminum hydroxide for control of hyperphosphatemia. Chronic use of magnesium-containing antacids is not advisable in patients with renal insufficiency. 9. Constipation can occur in patients using calcium carbonate and aluminum-containing antacids. 10. Diarrhea is a common adverse effect of magnesium-containing antacids. If diarrhea occurs, the patient may alternate the antacid mixture with aluminum hydroxide. Hypophosphatemia and osteomalacia can occur with long-term use of aluminum hydroxide, but these conditions can also occur with short-term use in severely malnourished patients, such as alcoholics. Significant interactions. Because antacids alter gastric pH and affect absorption of ingested substances, they have a high potential for drug interactions. To ensure consistent absorption and therapeutic efficacy, orally administered drugs should be given 30 to 60 mins before antacids. 1. Antacids bind with tetracycline and fluoroquinolones, inhibiting the absorption and reducing therapeutic efficacy. 2. Antacids may destroy the coating of enteric-coated drugs, leading to premature drug dissolution in the stomach. 3. Antacids may interfere with the absorption of many drugs, including cimetidine, ranitidine, digoxin, isoniazid, anticholinergics, iron products, and phenothiazines. C2. Antacids may reduce the therapeutic effects of sucralfate. C2. 3D. 2. H2 receptor antagonists. These drugs may be preferred to other anti-ulcer agents because of their convenience and lack of effect on GI motility. Although reasonably effective in treating mild to moderate GERD symptoms, H2 receptor antagonists are less reliable for healing erosive esophagitis. All current choices require multiple, divided doses for GERD management. Mechanism of action and therapeutic effects. H2 receptor antagonists competitively inhibit the action of histamine at parietal cell receptor sites, reducing the volume and hydrogen ion concentration of gastric acid secretions. Figure 44-3 and Table 44-2. These agonists accelerate the healing of most ulcers. peptic ulcer disease and related acid-associated disorders 895. Figure 44-3. Sites of drug action in a parietal cell. HCl, hydrochloric acid, PPIs, proton pump inhibitors. Table 44-2H2 receptor antagonists. Cimetidine, ranitidine, famotidine, azatidine. Characteristic: Tagamet, Zantac, pepsidoxid. Ring structure: imidazole, furan, thiazole, thiazole. Relative potency: 1/4 to 1020. 50 evening dose. mg active ulcer 800 340 300 maintenance 400 100 150 20 150 bioavailability 150 150 20 150 bio 150 bioavail volume of distribution 1 kg 1.4 1.1 1.4 0.8 1.6 protein binding 1.4 renal elimination 64 30 oral 70 65 70 65 75 intravenous half-life HR normal 223 2.5 4 1.6 anuric 4 5 4 4 4 5 6 anormal 6 in here. January 6, 40. Reprinted with permission from Hurwitz. Clinical Pharmacology of Agents for the Treatment of Acid-Related Disorders. In Zuckim D. Dannenberg AJ, ED. Peptic ulcer disease and other acid-related disorders. New York, New York, Academic Research Associates, 1991 343. B. Choice of agent. Cimetidine, Tigamet, Ranitidine, Zantac, Famotidine, Pepcid, or Nizatidine. Axid may be administered to treat peptic ulcers or hypersecretory states. For example, Zollinger-Ellison syndrome. 1. Cimetidine, the first H2 receptor antagonist approved for clinical use, reduces gastric acid secretion by approximately 50% at a total daily dosage of 1,000 milligrams. 896 Chapter 44-2. 2. Ranitidine, a more potent drug, causes a 70% reduction in gastric acid secretion at a total daily dosage of 300 milligrams. 3. Famotidine is the most potent H2 receptor antagonist. After a 40 mg dose, mean nocturnal gastric acid secretion is reduced by 94% for up to 10 HRS. 4. Nizatidine, the last H2 receptor antagonist marketed, causes a 90% reduction in nocturnal gastric acid secretion for up to 10 HR. C. Administration and dosage. 1. Cimetidine usually is administered orally in a dosage of 300 milligrams 4 times daily, with meals and at bedtime for up to 8 weeks. A. Alternatively, duodenal ulcer patients may receive 400 milligrams twice daily or 800 milligrams at bedtime. An 800 mg bedtime dose is also effective in treating gastric ulcers. P. Hospitalized patients may receive parenteral doses of 300 milligrams intravenously every 6 HRS. C. For duodenal ulcer prophylaxis, 400 milligrams may be given orally at bedtime. However, the ulcer recurs in 20–40% of patients. Cimetidine is also FDA approved for the prevention of upper GI bleeding at a dose of 50 milligrams sure continuous infusion. 2. Ranitidine usually is given orally in a dosage of 150 milligrams twice daily. Duodenal ulcer patients may receive 300 milligrams at bedtime. Alternatively, therapy continues for up to 8 weeks. A. Hospitalized patients may receive ranitidine by the intravenous or intramuscular route, 50 milligrams every 6 to 8 HRS. B. Prophylactic therapy may be administered to reduce the risk of ulcer recurrence. The approved prophylactic dosage is 150 milligrams at bedtime. Ranitidine 150 milligrams twice daily can be administered to maintain healing of erosive esophagitis. For this purpose, it is better than placebo, but less effective than the proton pump inhibitors. D. Ranitidine bismuth citrate, combined with antibiotics such as clarithromycin, is indicated for eradication of H. pylori in patients with duodenal ulcer. 3. Famotidine, administered to duodenal ulcer patients, is given in an oral dosage of 40 mg at bedtime for acute therapy for a maximum of 8 weeks. For prophylactic therapy, the dosage is 20 milligrams at bedtime. A. Hospitalized patients may receive an intravenous injection of 20 mg every 12 HRS. B. As with cimetidine and ranitidine, the ulcer may recur after drug discontinuation. 4. Nizatidine, for the treatment of duodenal ulcers, is given orally in a dosage of 300 milligrams once daily at bedtime or 150 milligrams twice daily for up to 8 weeks. For prophylactic therapy, the dosage is 150 milligrams at bedtime. D. Precautions and monitoring effects. 1. Ranitidine must be used cautiously in patients with hepatic impairment. Hepatotoxicity is unusual and occurs most often during intravenous administration. Cimetidine has also been associated with hepatotoxicity. 2. Cimetidine may cause such hematological disorders as thrombocytopenia, agranulocytosis, and aplastic anemia. 3. All these agents may cause headache and dizziness. Cimetidine additionally may lead to confusion, particularly if patients are more than 60 years of age or if the dosage is not adjusted for patients with decreased kidney or liver function. All agents require dosage reductions in patients with impaired renal function. Cimetidine has a weak androgenic effect, possibly resulting in male gynecomastia and impotence. Cimetidine and ranitidine rarely can cause bradycardia, which is reversible on discontinuation of therapy. 6. Evaluate H. pylori status in any patient with confirmed ulcer disease. Eradication of H. pylori reduces the need for maintenance therapy in patients with duodenal or gastric ulcers. Patients with complicated ulcer disease should continue maintenance therapy until the eradication of H. pylori. 7. Tolerance develops frequently to H2 receptor antagonists, TURAs, and may explain diminished responses to these agents over time. Peptic ulcer disease and related acid-associated disorders 897. E. Significant interactions. Cimetidine binds the cytochrome P450 system of the liver, and thus may interfere with the metabolism of such drugs as phenytoin, theophylline, phenobarbital, lidocaine, warfarin, imipramine, diazepam, and propranolol. 2. Cimetidine decreases hepatic blood flow, possibly resulting in reduced clearance of propranolol and lidocaine. 3. Antacids impair absorption of cimetidine and ranitidine and should be given 1 HR apart from these drugs. 4. Concomitant use of an H2 and an azole drug has resulted in decreased efficacy. 3. Sucralfate carafate. This mucosal protectant is a non-absorbable disaccharide containing sucrose and aluminum. A. Mechanism of action and therapeutic effects. Sucralfate adheres to the base of the ulcer crater, forming a protective barrier against gastric acids and bile salts. 1. Sucralfate's ulcer healing efficacy compares favorably to that of the H2Rs. Duodenal ulcers respond better than gastric ulcers to sucralfate therapy. B. Administration and dosage. 1. An oral agent. Sucralfate usually is given in a dosage of 1 gram 4 times daily, 1 HR before meals, and at bedtime, unless radiography or endoscopy documents earlier ulcer healing. Therapy continues for 4 to 8 weeks. 2. Continued sucralfate therapy after remission postpones ulcer relapse more effectively than cimetidine therapy does. 3. There is no evidence that combining sucralfate with H2Rs improves healing or reduces recurrence rates. C. Precautions and monitoring effects. Constipation is the most common adverse effect of sucralfate. D. Significant interactions. 1. Antacids may reduce mucosal binding of sucralfate, decreasing its therapeutic efficacy, and thus should be given 30 to 60 mins apart from sucralfate if used in combination ulcer therapy. 2. Sucralfate may interfere with the absorption of orally administered digoxin, tetracycline, phenytoin, iron, ciprofloxacin and other fluoroquinolones, and cimetidine if doses are given simultaneously. 4. GI anticholinergics, for example, belladonna leaf, atropine, propantholines sometimes are used as adjunctive agents for relief of refractory duodenal ulcer pain. However, these agents have no proven value in ulcer healing. Mechanism of action. Anticholinergics decrease basal and stimulated gastric acid and pepsin secretion. 1. Given in combination with antacids, anticholinergics delay gastric emptying, thereby prolonging antacid retention. They are most effective when taken at night and in large doses. 2. Anticholinergics occasionally are used in patients who do not respond to HWARAs alone. B. Administration and dosage. One taken 30 mins before food. Anticholinergics inhibit meal-stimulated acid secretion by 30% to 50% for a duration of 4 to 5 HRS. 2. The optimal effective dose varies from patient to patient. C. Precautions and monitoring effects. 1. All anticholinergics have side effects to varying degrees, such as dry mouth, blurred vision, tachycardia, urinary retention, and constipation. 2. These drugs are contraindicated in patients with gastric ulcers because they prolong gastric emptying. They also are contraindicated in patients with narrow-angle glaucoma and urinary retention. 5. Prostaglandins. These agents suppress gastric acid secretion and may guard the gastric mucosa against damage from NSAIDs. Misoprostol, Cytotec, has been approved for use in the prevention of gastric ulcers caused by NSAIDs. Mechanism of action. Misoprostol has both anti-secretory, inhibiting gastric acid secretion, and mucosal protective properties. NSAIDs inhibit prostaglandin synthesis, and a deficiency of prostaglandin within the gastric mucosa may lead to diminishing bicarbonate. 898, Chapter 44-2. And mucus secretion, contributing to the mucosal damage caused by NSAIDs. Misoprostol increases bicarbonate and mucus production at doses of 200 mcg and above, doses that can also be anti-secretory. Misoprostol also maintains mucosal blood flow. B. Administration and dosage. 1. Misoprostol is indicated for the prevention of NSAID-induced gastric ulcers in patients at high risk for complications from gastric ulcers. For example, patients more than 60 years of age, patients with concomitant debilitating disease, patients with a history of ulcers. 2. Misoprostol has not been shown to prevent duodenal ulcers in patients taking NSAIDs. 3. The recommended adult dosage is 200 mcg 4 times daily with food. It must be taken for the duration of NSAID therapy. If this dose cannot be tolerated, 100 mcg 4 times daily can be used. Adjustment of dosage in renally impaired patients is not routinely needed. C. Precautions and monitoring effects. 1. Misoprostol is contraindicated in pregnant women because of its abortifacient property. Patients must be advised of the abortifacient property and warned not to give the drug to others. 2. Misoprostol should not be used in women with childbearing potential unless the patient requires NSAID therapy and is at high risk of complications from gastric ulcers associated with use of the NSAIDs, or is at high risk of developing gastric ulceration. In such a patient, misoprostol may be prescribed if the patient A. is capable of complying with effective contraceptive measures, B. has received both oral and written warnings of the hazards of misoprostol, the risk of possible contraception failure, and the danger to other women of childbearing P. Potential should the drug be taken by mistake. C. Had a negative serum pregnancy test within 2 weeks before beginning therapy. D. Began misoprostol only on the second or third day of the next normal menstrual period. 3. The most frequent adverse effects are diarrhea, 14% to 40%, and abdominal pain, 13% to 20%. Diarrhea is dose-related, usually develops early in the course, 2 weeks, and is often self-limiting. Discontinuation of misoprostol is necessary in about 2% of patients. Administration with food minimizes the diarrhea. D. Significant interactions. None has been reported. 6. Proton pump inhibitors (PPIs). Omeprazole Prilosec was the first TPI available in the United States, followed by lansoprazole Prevacid, Riprazole Osifex, Pantoprazole Protonix, Esomeprazole Nexium, and Dexlansoprazole Capid. See Table 44-3. The intravenous forms. Table 44-3 proton pump inhibitors. Pharmacokinetics of PPIs. Omeprazole, lansoprazole, riprazole, pantoprazole. Characteristic Prilosec, Prevacid. Bioavailability. Bio 764 theta non-applicable time to peak plasma. 0.5, 3.5, 1.72, 5, 1.1, 3.1, 1.56 first peak 1, 2. Concentration second peak hours 4. 5 plasma elimination 0.5, 1, 1.3, 1.71, 1.51, 0.85, 1.25, 1, 2. Half-life, Lun. Protein binding, 95, 97, 96, 98, 97, 97, 97, 97, 97. And 9790. Oral dose. PPIs. Proton pump inhibitors. Peptic ulcer disease and related acid-associated disorders 899. Esomeprazole, lansoprazole, and pantoprazole have been approved by the Food and Drug Administration, FDA. The mechanism of action and therapeutic effects. The gastric proton pump HEK pace has a sulfhydryl group near the potassium binding site on the luminal side of the canalicular membrane. Omeprazole sulfonamide, the active form, forms a stable disulfide bond with this specific sulfhydryl, thereby inactivating the ATPase and shutting off acid secretion. All other PIs exhibit a similar irreversible mechanism of action. 1. Because of the potency and marked reduction in gastric acidity, the PPIs are more rapidly effective than other approved agents in treating peptic ulcer disease. That is, PPIs tend to control symptoms and heal ulcers more rapidly than other anti-ulcer drugs. PPIs provide effective healing of duodenal ulcers. Healing rates at 4 weeks are similar to those reported for H2 receptor antagonist therapy at 8 weeks. All PPIs are effective in healing erosive esophagitis, provide more rapid symptom relief and more consistent healing than H2 receptor antagonists, and are also effective in maintenance of healing of erosive esophagitis. 3. All PPIs except dexlansoprazole and pantoprazole have been approved in various combinations of antibiotics for the eradication of H. pylori. Table 44-4. PPIs have resulted in significant improvement in patients with pathological hypersecretory conditions, Zollinger-Ellison syndrome, and GERD compared to H receptor antagonists. Esomeprazole and lansoprazole have been approved by the FDA for healing and risk reduction of NSAID-induced gastric ulcers. 6. Esomeprazole, omeprazole, and lansoprazole have been approved by the FDA for use in infants and children for the short-term treatment of GERD and erosive esophagitis. Omeprazole is approved for use in children ages 1 to 16 years. And both esomeprazole and lansoprazole are approved for use in children 1 to 11 years old. Table 44-4 U.S. Food and Drug Administration. Six. Esomeprazole, omeprazole, and lansoprazole have been approved by the FDA for use in infants and children for the short-term treatment of GERD and erosive esophagitis. Omeprazole is approved for use in children ages 1 to 16 years, and both esomeprazole and lansoprazole are approved for use in children 1 to 11 years old. Table 44-4 U.S. Food and Drug Administration FDA-approved oral regimens used to eradicate Helicobacter pylori and reduce the risk of duodenal ulcer recurrence. Drug combination dose and frequency duration. Omeprazole 20 mg BID. Days 1 10 20 mg QD. Days 11 28. Clarithromycin 500 mg B. Days 1 10 amoxicillin 1 gram B. Days 1 lansoprazole 30 mg B. I. 10 days amoxicillin 1 gram B. 10 days clarithromycin 500 mg B. 10 days esomeprazole 40 mg QD. QD. 10 days amoxicillin 1 gram B. 10 days clarithromycin 500 mg B. ID. 10 days raprazole 20 mg B. 7 days amoxicillin 1 gram B. 7 days clarithromycin 500 meters. 7 days bismuth subsalicylate 525 mg QID. Days 114 metronidazole 250 mg Q. Days 114 tetracycline HCl 500 mg Q. Days 114 HWR of choice ulcer healing regimen. Days 128. In patients with an ulcer present at the time of initiation of therapy, additional omeprazole treatment is recommended for ulcer healing and relief of symptoms. B. Twice a day. H2 histamine H2 receptor antagonist. Q. Every day. Q. Up. Fort. 900 Chapter 40. 4-2. B. Administration and dosage. 1. PPIs are more potent than H2 blockers. In the usual dosage, omeprazole 20 mg daily, these agents inhibit 90% of December 24, 2023 acid secretion in most patients, rarely producing achlorhydria. Desomeprazole 40 mg daily provided significantly higher intragastric pH values above 4 during 24-HR monitoring compared to lansoprazole 30 mg, rabeprazole 20 mg, omeprazole 20 mg, and pantoprazole 40 mg. 2. PPIs should optimally be taken in the morning 30 to 60 minutes before eating. Food activates parietal cells, maximizing the effect of the PPI. Optimal binding to proton pumps occurs when the pumps are actively secreting. 3. Recommended adult dosages. Erosive esophagitis initially is healed with 20 mg omeprazole or equivalent doses of other PIs for 8 to 12 weeks. Only omeprazole has a demonstrated dose response. In GERD patients failing omeprazole 20 mg daily may benefit from higher doses. This has not been demonstrated with esomeprazole, lansoprazole, rabeprazole, or pantoprazole. In addition, esomeprazole erosive esophagitis initially is healed with 20 mg omeprazole or equivalent doses of other PIs for 8 to 12 weeks. Only omeprazole has a demonstrated dose response. In GERD patients failing omeprazole 20 mg daily may benefit from higher doses. This has not been demonstrated with esomeprazole, lansoprazole, rabeprazole, or pantoprazole. In addition, esomeprazole 40 mg every day has been shown to produce significantly higher healing rates than omeprazole 20 mg or lansoprazole 30 mg across all grades of erosive esophagitis. B. Dexlansoprazole 30 mg, esomeprazole 20 to 40 mg, lansoprazole 30 mg, omeprazole 20 mg, rabeprazole 20 mg, and pantoprazole 40 mg may be used to manage GERD symptoms in patients who have failed previous therapy with H2 receptor antagonist therapy. C. The recommended dosage to maintain healing of erosive esophagitis is dexlansoprazole 30 mg, esomeprazole 20 mg, omeprazole 20 mg, lansoprazole 15 mg, pantoprazole 40 mg. Or rabeprazole 20 mg daily for as long as medically necessary. D. Duodenal ulcer healing requires omeprazole 20 mg, lansoprazole 15 mg, or rabeprazole 20 mg once daily. Most patients heal within 4 weeks. Esomeprazole, lansoprazole, and omeprazole are delayed-release capsules and should be taken before eating, can be used concomitantly with antacids, and should not be chewed or crushed. Capsule contents can be sprinkled on foods, that is, applesauce, or mixed with acidic juices. Suspensions of omeprazole or lansoprazole and sodium bicarbonate have been used for administration to patients with nasogastric and jejunostomy tubes. 5. Rabeprazole and pantoprazole are available as enteric-coated tablets that should not be crushed or chewed. 6. Lansoprazole is available as the first orally disintegrating tablet formulation. It is placed on the tongue, with or without water, until dissolved. However, it needs to be swallowed to be absorbed. 7. Dexlansoprazole is the first and only PKI available as a dual delayed-release capsule formulation. 8. Omeprazole and sodium bicarbonate powder for suspension. Zegerid is the first PKI approved by the FDA for reduction in the risk of upper GI bleeding in critically ill patients. It has a peach mint flavor that is tolerable. It is dosed at 40 mg every 6 HRS times 2 doses, as a loading dose, then 40 mg daily. 20 mg daily, and lansoprazole 15 mg daily, are approved for the over-the-counter use of heartburn. 10. No dosing adjustments are necessary in patients with impaired renal or hepatic function or in the elderly. Intravenous pantoprazole is indicated for management of erosive esophagitis and treatment of Zollinger-Ellison syndrome. Omeprazole, lansoprazole, and pantoprazole are currently being widely used for the treatment of acute bleeding gastric ulcers, though not FDA approved. 12. Intravenous esomeprazole, 20 to 40 mg daily. Lansoprazole 30 mg daily, and pantoprazole 40 mg daily, are FDA approved for the short-term use in patients with GERD with a history of erosive esophagus, unable to take oral medications. 13. In patients with nocturnal signs and symptoms of GERD, twice-daily PPIs have been effective when taken appropriately. The addition of an H-TORA to the twice-daily PI has shown little added benefit and is not recommended. Peptic ulcer disease and related acid-associated disorders 901. C. Precautions and monitoring effects: 1. Headache, diarrhea, abdominal pain, nausea, and vomiting, and flatulence have been reported in 1% of patients. 2. Fever, fatigue, malaise, elevated liver enzymes, dizziness, vertigo, skin rash, and itching have been reported in 1% of patients. D. Significant interactions: 1. Omeprazole interferes with the hepatic microsomal enzyme metabolism, cytochrome P450 of diazepam, warfarin, and phenytoin, although clinically significant interactions are infrequent. 2. PPIs may decrease the antiplatelet activity of clopidogrel, but the exact clinical significance is still unclear. 3. Because gastric pH plays a role in the bioavailability of ketoconazole, ampicillin esters, and iron salts, prolonged gastric acid inhibition with PPIs may decrease the absorption of these agents. 4. Antacids may be used concomitantly with all PPIs. As food may reduce the bioavailability of esomeprazole and lansoprazole by 50%. Food does not reduce the bioavailability of omeprazole or rabeprazole. 7. Bismuth compounds. In the United States, bismuth subsalicylate, Pepto-Bismol, is the only available bismuth product. A. Mechanism of action. Bismuth prevents adhesion of H. pylori to gastric mucosa, decreases resistance when used with other anti-I. Pylori agents, inhibits release of proteolytic enzymes, and suppresses H. pylori growth. B. Administration and dosage. 1. Bismuth subsalicylate is highly effective when combined with PPIs and/or antibiotics. Eradication rates with these combinations are 80%. Table 44-4. Preferred regimen with bismuth. Bismuth subsalicylate 525 mg 4 times a day. Metronidazole 250 mg 4 times a day. Tetracycline 500 mg 4 times a day plus PPI. Omeprazole 20 mg every day, or lansoprazole 30 mg every day for 2 weeks total. This regimen provides consistently high eradication rates, 90%, and may be useful for patients who have failed previous therapy. This regimen is not currently FDA approved. C. Precautions and monitoring effects. 1. CNS toxicity with higher doses, including neurotoxicity. 2. Tinnitus, hyperpyrexia, tachycardia. In confusion, salicylism from high doses of bismuth subsalicylate D. Reversible proton pump inhibitors are currently under development by a number of pharmaceutical companies, AstraZeneca and Altana. When compared with the currently available irreversible proton pump inhibitors, these agents are expected to offer more rapid symptom resolution, control pH more quickly, achieve higher pH levels, and sustain these more aggressive pH levels consistently over a 24-hour period. The sedatives are useful adjuncts in promoting rest for highly anxious ulcer patients. B. Other therapeutic measures. 1. Modification of diet and social habits. A. Previously emphasized in ulcer therapy, strict dietary limitations now are considered largely unnecessary. 1. Bland or milk-based diets formerly were recommended. However, research indicates that these diets do not speed ulcer healing. In fact, most experts now advise ulcer patients to avoid milk because recent studies show that milk increases gastric acid secretion. Also, because milk leaves the stomach quickly, it lacks an extended buffering action. Bar 2. Small, frequent meals, also previously recommended, can worsen ulcer pain by causing acid rebound 2 to 4 HRS after eating. B. Current dietary guidelines emphasize avoiding foods and beverages known to exacerbate gastric discomfort or promote acid secretion. This category typically includes coffee, caffeinated beverages, and alcohol. C. Smoking. Patients who smoke should be encouraged to quit because smoking markedly slows ulcer healing, even during optimal ulcer therapy. D. NSAIDs should be avoided by ulcer patients. 902 Chapter 44-2. B. 2. Surgery. An ulcer patient who develops complications may require surgery, sometimes on an emergency basis. See the third. Incapacitating recurrent ulcers also may warrant surgery. Types of surgical procedures for ulcer disease include entrectomy and truncal vagotomy, Billroth procedure, partial gastrectomy and truncal vagotomy, Billroth II procedure, highly selective proximal gastric vagotomy, and total gastrectomy, the treatment of choice for Zollinger Ellison syndrome that is unresponsive to medical management. 1. A vagotomy severs a branch of the vagus nerve, thereby decreasing HCl secretion. 2. An antrectomy, by removing the antrum, eliminates some acid-secreting mucosa as well as the major source of gastrin. B. The general indications for entire flux surgery are failure of medical therapy to heal or prevent relapse of erosive esophagitis, inability of medical therapy to prevent recurrence of stricture, or a patient whose lifestyle is adversely affected by the need for medical therapy. Laparoscopic fundoplication is currently the gold standard for GERD and successfully relieves symptoms and heals lesions in approximately 85% of patients. However, Recent studies have demonstrated that most patients require continued medical therapy after fundoplication. 3. Emerging endoscopic therapies. 3 endoscopic techniques to treat GERD have recently been introduced. A. Augmentation of list pressure may be achieved by delivery of radiofrequency energy to the muscle of the gastroesophageal junction. Strata procedure. The radiofrequency is delivered by means of a flexible catheter made up of a bougie tip, a balloon basket combination, and 4 needle delivery sheaths. B. Another endoscopic procedure, the endocinch, augments the list by suturing of the mucosa. The third endoscopic endoluminal treatment is by use of enterix injection. D. Early studies have demonstrated good feasibility in performing these procedures and an overall satisfactory safety profile. Further studies are necessary to assess long-term failure rate, early versus late complications, and success rate in the different GERD groups. Third, complications of peptic ulcer disease cause approximately 7,000 deaths in the United States annually. Hemorrhage. This life-threatening condition develops from widespread gastric mucosal irritation or ulceration with acute bleeding. 1. Clinical features. The patient may vomit fresh blood or a coffee grounds-like substance. Other signs include passage of bloody or tarry stools, diaphoresis, and syncope. With major blood loss, manifestations of hypovolemic shock may appear. The pulse rate may exceed 110, or systolic blood pressure may drop below 100. 2. Management. Patient stabilization, bleeding cessation, and measures to prevent further bleeding are crucial. 1. Airway, breathing, and circulation must be ensured. 2. Intravenous crystalloids and colloids, for example, Hedastark, should be infused as needed. The patient's electrolyte status must be monitored, and any imbalances should be corrected promptly. B. Gastric lavage may be performed via a nasogastric or orogastric tube. Ice saline solution is instilled until the aspirate returns free of blood. C. Vasoconstrictors or continuous infusion proton pump inhibitors have been administered with good response. 1. Decreased rebleeding rates were found when the continuous infusion PPI maintained the gastric pH to 6 or above. The doses required were much higher than normal doses. For example, pantoprazole 80 kg bolus plus 8 mg SIR or lansoprazole 90 mg bolus plus 9 mg SIR. However, none of the intravenous PKIs are currently FDA approved for this indication. 2. Vasopressin, an agent that causes contraction of the GI smooth muscle, may be given to constrict vessels and control bleeding, but only in patients with hemorrhagic gastritis. D. Emergency surgery usually is indicated if the patient does not respond to medical management. Peptic ulcer disease and related acid-associated disorders 903. B. Perforation. Penetration of a peptic ulcer through the gastric or duodenal wall results in this acute emergency. Perforation most commonly occurs with ulcers located in the anterior duodenal wall. 1. Clinical features. Sudden acute upper abdominal pain, rigidity, guarding, rebound tenderness, and absent or diminished bowel sounds are typical manifestations. Several hours after onset, symptoms may abate somewhat. This apparent remission is dangerously misleading because peritonitis and shock may ensue. 2. Management. Emergency surgery is almost always necessary. C. Obstruction. Inflammatory edema, spasm, and scarring may lead to obstruction of the duodenal or gastric outlet. The pylorus and proximal duodenum are the most common obstruction sites. 1. Clinical features. Typical patient complaints include postprandial vomiting or bloating, appetite and weight loss, and abdominal distension. Tympany and a succussion splash may be audible on physical examination. Gastric aspiration after an overnight fast typically yields more than 200 milliliters of food residue or clear fluid contents. Gastric cancer must be ruled out as the cause of obstruction. 2. Management. Conservative measures, as in routine ulcer therapy, are indicated in most cases of obstruction. B. Patients with marked obstruction may require continuous gastric suction with careful monitoring of fluid and electrolyte status. A saline load test may be performed after 72 hours of continuous suction to test the degree of residual obstruction. C. If 200 milliliters of gastric contents are aspirated, liquid feedings can begin. Aspiration is performed at least daily for the next few days to monitor for retention and to guide dietary modifications as the patient progresses to a full regular diet. D. Surgery is indicated if medical management fails. D. Post-surgical complications. 1. Dumping syndrome. Affecting about 10% of patients who have undergone partial gastrectomy, this disorder is characterized by rapid gastric emptying. Causes. The mechanism underlying dumping syndrome is poorly defined. However, intestinal exposure to hypertonic chyme may play a key role by triggering rapid shifts of fluid from the plasma to the intestinal lumen. B. Clinical features. The patient may experience weakness, dizziness, anxiety, tachycardia, flushing, sweating, abdominal cramps, nausea, vomiting, and diarrhea. 1. Manifestations may develop 15 to 30 minutes after a meal. Early dumping syndrome, or 90 to 120 minutes after a meal. Late dumping syndrome. 2. Reactive hypoglycemia may partly account for some cases of late dumping syndrome. C. Management. The patient usually is advised to eat 6 small meals of high protein and fat content and low carbohydrate content. Fluids should be ingested 1 hours before or after a meal, but never with a meal. Anticholinergics may be given to slow food passage into the intestine. 2. Other post-surgical complications include reflux gastritis, afferent blind loop syndrome, stomal ulceration, diarrhea, malabsorption, early satiety, and iron deficiency anemia. E. Refractory ulcers. Ulcers that fail to heal on a prolonged course of drug treatment should not be confused with ulcers that recur after therapy is stopped. It is difficult to predict which patients will have a refractory ulcer. 1. Differential diagnosis. Any compliant patient who continues to have dyspeptic symptoms after 8 weeks of therapy should have gastroscopy and biopsy to exclude rare causes of ulceration in the duodenum, such as Crohn's disease, tuberculosis, lymphoma, pulmonary or secondary carcinoma, and cytomegalovirus (CMV) infection in immunodeficient patients. Fasting plasma gastrin concentration should be measured to exclude Zollinger-Ellison syndrome. 2. Treatment. Available data indicate that only maximum acid inhibition, with a regimen such as omeprazole 20 mg twice a day or lansoprazole 30 mg twice a day, offers advantages over continued therapy with standard anti-ulcer regimens. B. Eradication of H. pylori infection, when present, is likely to facilitate healing and alter the natural history of refractory ulcers. 904 Chapter 44 3rd. E. C. Every effort should be made to discover and reduce or eliminate NSAID use. D. Perform surgery. Maintenance regimens. 1. Despite healing after withdrawal of therapy, 70% of ulcers recur in 1 year, and 90% in 2 years. Similarly, erosive esophagitis will recur in more than 80% of individuals within 1 year after discontinuation of anti-secretory therapy. 2. Candidates for long-term maintenance therapy include patients with serious concomitant diseases, 4 relapses per year, or a combination of risk factors producing a more severe natural history of peptic disease, for example, old age, male sex, a long history of aspirin or NSAID use, heavy alcohol intake, cigarette smoking, a history of peptic ulcer disease and an immediate relative, high maximal acid output, and a history of ulcer complications. 3. Patients with confirmed ulcer disease should be evaluated for presence of H. pylori. Eradication of H. pylori minimizes the recurrence of ulcer disease. Patients with a history of complicated ulcer disease should have H. pylori eradication confirmed. Study questions. Directions for questions 1. Each of the questions, statements, or incomplete statements in this section can be correctly answered or completed by one of the suggested answers or phrases. Choose the best answer. ZZ is a year-old female with a chief complaint of hematemesis and abdominal pain. Serology is positive for H. pylori. Which of the following would be the best regimens to treat ZZ? A. Omeprazole 20 mg daily plus clarithromycin 500 mg b. 14 days. B. Lansoprazole 30 mg b. I+, tetracycline 500 mg q. 14 days. C. Raprazole 20 mg b. plus amoxicillin 1 gram b. ID. plus clarithromycin 500 mg b. 7 days. D. Someprazole 40 mg b. A plus amoxicillin 500 mg b. plus clarithromycin 500 mg b. 7 days. E. Pantoprazole 40 mg b.i.d. plus amoxicillin 1 gram b.i.d. plus clarithromycin 500 mg t. 10 days. 102. All of the following statements concerning antacid therapy used in the treatment of duodenal or gastric ulcers are correct except which one? Antacids may be used to heal the ulcer but are ineffective in controlling ulcer pain. B. Antacids neutralize acid and decrease the activity of pepsin. If used alone for ulcer therapy, antacids should be administered 1 HR and 3 HRS after meals and before bedtime. D. If diarrhea occurs, the patient may alternate the antacid product with aluminum hydroxide. E. Calcium carbonate should be avoided because it causes acid rebound and induces constipation. 3. As part of a comprehensive management strategy to treat peptic ulcer disease, patients should be encouraged to do all of the following except A. Decrease caffeine ingestion. Eat only bland foods. C. Stop smoking. Avoid alcohol. Avoid the use of milk as a treatment modality. 4. A gastric ulcer patient requires close follow-up to document complete ulcer healing because perforation into the intestine is common. Autonomic or spontaneous healing of the ulcer may occur in 30% to 50% of cases. C. There is the risk of the ulcer being cancerous. D. Symptoms tend to be chronic and recur. E. Weight loss may be severe in gastric ulcer patients. 5. It is a 58-year-old male admitted to the intensive care unit with acute respiratory failure and thrombocytopenia. He is at high risk for an upper gastrointestinal bleed. Which of the following agents are approved by the U.S. Food and Drug Administration, FDA, for the prevention of this type of bleed? A. Sucralfate, B. Famotidine, C. Esomeprazole, D. Lansoprazole, omeprazole, peptic ulcer disease and related acid-associated disorders 905. 6. All of the following provide acid suppression similar to omeprazole 20 mg every day except A. Dexlansoprazole 30 mg every day, B. Pantoprazole 40 mg every day, C. Riprazole 20 mg every day, Rentundidine 150 mg twice a day. All provide equivalent acid suppression. Directions for questions 7. The questions and incomplete statements in this section can be correctly answered or completed by one or more of the suggested answers. Choose the answer. E. A if I only is correct, B if the third only is correct, C if I and second are correct, D if 2 and the third are correct, D if I, 2 and the third are correct. 7. Correct statements concerning cigarette smoking and ulcer disease include which of the following? I. Smoking delays healing of gastric and duodenal ulcers. Nicotine decreases biliary and pancreatic bicarbonate secretion. Ard. Smoking accelerates the emptying of stomach acid into the duodenum. 8. When administered at the same time, antacids can decrease the therapeutic efficacy of which of the following drugs? Sucralfate, bernetidine, duracemetidine. Directions for questions 9-13. Each description in this section is most closely associated with one of the following agents. Each agent is used only once. Choose the best answer. E. A sodium bicarbonate, B. Aluminum hydroxide, C. Calcium carbonate, D. Magnesium hydroxide, E. Propantholine. 9. May cause diarrhea. 10. Cannot be used by patients with heart failure. 11. If used with milk and an alkaline substance can cause milk alkali syndrome. 12. May cause dry mouth. 13. Can be alternated with an antacid mixture to control diarrhea. Answers and explanations. 1. The answer is C. See Table 44-4. Though all agents are useful in the treatment of Helicobacter pylori, only the combination of rabeprazole with amoxicillin and clarithromycin for 7 days is correct. The other doses and duration of therapy are incorrect. 2. The answer is A. C. Antacids have been shown to heal peptic ulcers, and their main use in modern therapy is to control ulcer pain. Antacids should be taken 1-HR and 3-HRS after meals because the meal prolongs the acid buffering effect of the antacid. If diarrhea becomes a problem with antacid use, an aluminum hydroxide product can be alternated with the antacid mixture. This takes advantage of the constipating property of aluminum. Because calcium carbonate causes acid rebound and constipation, its use should be avoided. 3. The other doses and duration of therapy are incorrect. 2. The answer is A. C. Antacids have been shown to heal peptic ulcers, and their main use in modern therapy is to control ulcer pain. Antacids should be taken 1-HR and 3-HRS after meals because the meal prolongs the acid buffering effect of the antacid. If diarrhea becomes a problem with antacid use, an aluminum hydroxide product can be alternated with the antacid mixture. This takes advantage of the constipating property of aluminum. Because calcium carbonate causes acid rebound and constipation, its use should be avoided. 3. The answer is B. C2B. Bland food diets are no longer recommended in the treatment of ulcer disease because research indicates that bland or milk-based diets do not accelerate ulcer healing. Studies show that patients can eat almost anything. However, they should avoid foods that aggravate their ulcer symptoms. 4. The answer is C. CID 6. Between 5% and 10% of gastric ulcers may be the result of cancer. The ulcer may respond to therapy. However, failure of the ulcer to decrease satisfactorily in size and to heal with therapy may suggest cancer. Close follow-up is necessary to document complete ulcer healing. 5. The answer is E. C2. Though all of these agents have been used with success in the prevention of GI bleeds in critically ill patients, only omeprazole, as a powder for oral suspension, has been FDA approved for this indication. Six. The answer is D. C2. Doses of omeprazole 20 milligrams, dexlansoprazole 30 milligrams, pantoprazole 40 mg, and rayoprazole 20 milligrams administered once daily provide similar levels of acid suppression. All provide significantly better acid inhibition than ranitidine, even at doses of 150 milligrams twice a day or more. (906) Chapter 44. 7. The answer is E. The answer is E. Clinical studies have shown that smoking increases susceptibility to ulcer disease, impairs spontaneous and drug-induced healing, and increases the risk and rapidity of recurrence of the ulcer. These findings may result in part from nicotine's ability to decrease biliary and pancreatic bicarbonate secretion, thus decreasing the body's ability to neutralize acid in the duodenum. Also, the accelerated emptying of stomach acid into the duodenum may predispose to duodenal ulcer and may decrease healing rates. 8. The answer is E. I. The 3. C2. The mean peak blood concentration of cimetidine and the area under the 4-HR cimetidine blood concentration curve were both reduced significantly when cimetidine was administered at the same time as an antacid. The absorption of ranitidine is also reduced when it is taken concurrently with an aluminum magnesium hydroxide antacid mixture. To avoid this interaction, the antacid should be administered 1-HR before or 2-HRs after the administration of cimetidine or ranitidine. Antacids may reduce mucosal binding of sucralfate, decreasing its therapeutic efficacy. Antacids should, therefore, be given 30 to 60 minutes before or after sucralfate. 9. The answer is D. C2. 1, 3 is 10. The answer is A. C2. 11. The answer is C. C2. 12. The answer is E. C2 of 13. The answer is B. C2 equal 1. The answer. Gaining products tend to cause diarrhea, possibly because of magnesium's ability to stimulate the secretion of bile acids by the gallbladder. Because of its sodium content, sodium bicarbonate is contraindicated in patients with THF, hypertension, severe renal disease, and edema. Sodium bicarbonate is no longer used in peptic ulcer therapy. In addition to causing acid rebound, calcium carbonate, if taken with milk and an alkaline substance for long periods, may cause milk alkali syndrome. It also may cause adverse effects such as hypercalcemia, alkalosis, azotemia, and nephrocalcinosis. Propantholine, like other anticholinergic agents, may cause dry mouth, blurred vision, urinary retention, and constipation. These agents sometimes are used as adjuncts to relieve duodenal ulcer pain. They are contraindicated in gastric ulcer because they delay gastric emptying. Aluminum hydroxide is constipating and can be alternated with the patient's current antacid when that antacid product is causing diarrhea. (907) Diseases of the bowel